10 million people in the UK have had their first vaccine dose, and that is an incredible achievement and gives us real hope that this country and indeed the whole world will start to emerge from the shadow of the pandemic this year. But at the same time, new variants are emerging, introducing new uncertainties and new threats, and we absolutely can't afford to drop our guard and become complacent. One of the most pressing questions right now is when schools might be able to reopen, and more importantly, whether they'll be able to do so safely with measures put in place that weren't there in the autumn when cases surged. Professor Stephen Reicher is going to talk a bit about the new Independent Sage consultation document on schools, which you can read in full on our website as always. But before that, we will start with a look at the week's figures with Dr. Kit Yates. Over to you, Kit.
Sorry, thank you, Alice. I'm muted. You would have thought I'd known better by now. So this week overwhelmingly is a positive news week. For some reason, my slides aren't progressing forward, so I'm just going to stop sharing for a second and try and reshare, and hopefully that will resolve itself. Apologies for that. Let's try again. Okay, let's share and go to full screen. Okay, good. So finally, it's a good news week. Cases and positivity rates are continuing to decline. They've been declining for a few weeks now. Hospital admissions are also coming down, although they're still at high levels, as is hospital occupancy. Deaths are also declining now, have been for maybe a couple of weeks, but again, still at extremely high levels, reflecting the high levels of cases that we had in December and at the start of January. And rates of first doses of vaccination being given are also increasing. And as I said, we've vaccinated, or at least given the first dose of the vaccine to over 10 million people in the UK now. So that's all really good news. So I'm going to talk about these four different things and dive a bit more deeply into the data. So cases, hospitalizations, and then deaths, and then vaccination data. So looking at cases, firstly, so the green bars here are the number of daily cases per day confirmed by positive PCR test, and the black line is the 7-day rolling average of those figures. And you can see that they're continuing to decline. They have been since early January. There's something that we should say about the data. So previously, if people have tested positive using a lateral flow test, these are the sort of rapid tests that we use to mass test asymptomatic people. They're quicker and cheaper to use than PCR tests, which is why we use them, but they're slightly less accurate. But typically, if someone's tested positive with a lateral flow test, then they've been sent for confirmatory testing with a PCR test as well to make sure, and then those PCR tests will be what's reported. As of the 27th of January, so a week or so ago, it was decided that test capacity was not high enough for PCR. Rather, we were doing so many tests that actually we weren't going to confirm lateral flow device positives anymore. So actually these figures since the 27th of January include positives both from PCR tests, but also from these lateral flow tests. Now, I don't think this is a particular problem. It doesn't suggest that cases will be significantly over or underreported, especially when we have high prevalence in the community. But I think we should go back to using PCR confirmatory tests when the rates of the disease have come down sufficiently to allow that. I don't think we should be just reporting lateral flow results. So I thought that was something that I should let everyone know about in the data, that this is now happening. The other strange thing was that happened a couple of weeks ago after the briefing was that a journalist called Nicola Davis from The Guardian got in contact with me and said that our positivity rates were not matching what was appearing in Public Health England's positivity rates. And so this is the data for England. The reason we look at positivity rates is because sometimes testing can have an impact on the number of cases that you find. So if infections are staying constant and you start testing more, then you end up finding more cases, and it looks like cases are rising, infections are rising. And if you start testing less, then it looks like infections are falling. In fact, they may well be staying constant. So looking at the positivity rate, the proportion of tests which come back positive, is important to do. So the red line is the one that we report from the COVID dashboard, and the black dashed line is Public Health England. And you can see that they're starting to diverge quite significantly from each other. And so we looked into this, and we've been in contact with Public Health England about this. And it turns out that the reason that there's a big divergence is that, despite saying in their report, Public Health England were using just PCR tests, it turns out they're actually using lateral flow tests in their positivity calculations. Now, because lateral flow tests are often used to test asymptomatic people, they have much lower positivity rates than PCR tests, which are typically used to test symptomatic people. So including those lateral flow tests in the figures appears to make the positivity rate come down, or look like it's coming down more quickly. In short, you're not comparing apples with apples over time. So you can see the same picture of the regional positivity rates. On the left here is Public Health England's figures, and on the right are the ones that we're using. Ours show much higher positivity rates and slower declines, whereas Public Health England's have shown very rapid declines, because lateral flow testing has increased quite a lot since January. So the proportion of positives has decreased quite a lot because of these lateral flow tests. So we've been in contact with Public Health England about that, and we won a small victory in that they've now corrected in their report that they are saying that their figures are from PCR and lateral flow tests. We are going to continue to report just using PCR tests, because that means we can compare things over time. We can compare apples with apples from week to week. So again, it seems like a small technicality in the data, but if you're using positivity rates to decide when and how we're going to open up, then it's important that you're comparing positivity rates in a consistent way over time. So it seems like a sort of nerdy data thing to be looking at, but it's actually a really important thing in terms of consistently looking at the metrics. So all that said, let's look at the cases per 100,000 in the 4 home nations. Again, you can see that these are falling. Red is England, black is Northern Ireland, green is Wales, and blue is Scotland. And you can see that they're falling quite rapidly now, which is good news, maybe tailing off slightly, but it's still coming down. Just to check, we'll look at the positivity rates that I've just been discussing. And again, you can see that they are falling. So this is genuine falls in infections rather than being impacted by changes in testing. This is also confirmed by the Office for National Statistics prevalence study. So they're looking at how many people have the disease at any point in time. So it's not quite the same as these incidence figures, which tells you how many people test positive per day. This is saying how many people are testing positive. You'd expect them to be linked, but the ONS figures will be a sort of smushed out, smoothed out version of these incidence figures. And indeed, that's what you see. So prevalence is now coming down, but it's perhaps it's more spread out. It's coming down at a slower rate than the incidences, which is unsurprising. So it's good that these two data sources are consistent. Similarly, if we drill down to the regional level in England, then we can see that the cases per 100,000 people in each of these regions in England are coming down. London's seen quite dramatic rise, quite dramatic falls. So this is also really good news, and that's also reflected in the positivity data. So again, taking the number of positive tests and dividing by the number of tests, we can be confident that infections genuinely are falling and that this lockdown is having an impact. Again, that's reflected in the prevalence rates from the ONS study that's in this inset here. Again, you can see London falling quite rapidly. Midlands, East Midlands and West Midlands are not falling quite as fast, and that's because prevalence, as I said, sort of smushes out the positivity rate from the incidence, and you can see that the West Midlands and the East Midlands actually had a little rise in positivity a couple of weeks ago and are now falling, but that's why their prevalence seems to be a bit flatter. But most regions are seeing falls in their prevalence as well as big falls in their incidence. So this is all good news. Drilling even further down to local authority levels, so I'll just describe these graphs again. The orange dot tells you the current positivity rate for a particular local authority. The grey dot tells you the positivity rate the week before that. So if the grey dot is above the orange dot, that means the positivity rate has fallen. And they're ranked from left to right by highest positivity to lowest positivity. So you can see that almost all local authorities have seen falls in their positivity rates in England. The same is true in Scotland. The same is true in Wales. And the same is true in Northern Ireland, where in fact all the local authorities have seen falls. It's important to emphasize, though, that these positivity rates are still really quite high across all local authorities. So although they're falling and things are going in the right direction, if you were to open things up now, for example, then these positivity rates would be extremely high and we would start to see rises in positivity again. Okay, so that's case data and positivity and a bit of technical stuff. Let's talk about hospitalizations now. So again, good news, hospital admissions are coming down, but they are still sitting at extremely high levels. So I've put on this line here of where the first wave peak of hospital admissions was, and you can see that it's only in the last week or so that we've really come below that first wave peak. So hospital admissions are still high. We need to keep those coming down because the hospital admissions turn into occupancy. Again, looking at the regional picture, you can see that hospital admissions are coming down in all regions. They started coming down first in London, probably reflecting the fact that London went into tier 4 first. Similarly with the east of England here and the southeast, they also were in tier 4 earlier on. And then you can see that places like the southwest and other regions started to fall a little bit later, but all regions are now falling in terms of their hospital admissions. And then looking at occupancy is now also falling. It's probably been falling for a couple of weeks, but we're still way, way above first peak hospital occupancy. And we were worried about overwhelming the NHS in the first wave. So we need these hospital admissions to continue to come down, and they will do because cases have been coming down, but we need to keep them coming down for weeks and weeks to come. So that's occupancy. And then the other thing which we don't touch on that often is critical care capacity. And this is actually where we're really worried about overwhelming things. So this is looking at the percentage of adult critical care beds that are occupied week on week. Again, the orange dot is this week, the grey dot is the week before. And what you can see is that there have been falls in almost all regions. The Midlands seen a slight rise, which probably reflects that rise in positivity we saw a couple of weeks ago. But mostly these adult critical care beds are becoming less occupied, which is good news. But again, to put it in perspective, despite the fact that they're falling week on week, this next plot shows you that those same falls in terms of absolute numbers of adult critical care beds that are occupied, but it also shows in these grey diamonds where we were this time last year. And so you can see that all regions have got higher occupancy in terms of the absolute numbers of their critical care beds which were occupied last year. And of course, remember that, last year this was still winter. We still had the usual seasonal pressure on the NHS, but London, for example, the number of critical care beds occupied in London is still over double what it was this time last year. So it's not as if things are better all of a sudden. There is still significant pressure on adult critical care beds. And you often hear people suggesting that that actually the NHS didn't get near to being overwhelmed because adult critical care beds stayed at around 95% capacity. And that's where they are every year. So to sort of debunk that myth, the orange lines here this is the capacity, the number of beds last year, and the dashed line is how many of them were occupied. So we didn't get close to that capacity. We were relatively close, but we didn't overwhelm it. This year, this blue line is the adult critical care bed capacity. You can see that it's been ramped up massively, and the dashed line is how many of those beds are occupied. So you can see that, yes, we still haven't breached the new capacity, but that's because we've increased the capacity significantly. If we hadn't increased capacity by taking over wards and turning them into critical care units, taking over operating theatres and turning them into critical care units, then we would have overwhelmed last year's adult critical care bed capacity by around 50%. So don't let people tell you that there isn't a problem and that we aren't, that this is a normal year and that these are normal NHS pressures, because that just isn't the case. Deaths, unfortunately, we have to talk about deaths. Again, the good news is that they are coming down now after being at record levels at least from the metric of 28 days within a positive within having a positive COVID test. You can see they've been falling for a couple of weeks now, which is good. I should say that this metric, as we always try to point out, doesn't mean quite the same thing as it did in the first wave, because we weren't testing as many people in the first wave. So we know that we missed some deaths by this figure in the first wave. So this isn't quite comparing the same thing, but either way, it's good to see the recent trend is that these deaths are coming down. If you want to do comparisons between the first wave and the second wave, then you need to use data from death certificates. And so this is reported with a lag because it takes time to register and collate all of that information. And so the latest data that came out was this data from the 22nd of January, the week ending the 22nd of January, where 9,056 deaths were recorded on death certificates. That compares to 9,495 at the peak of the first wave, so just below that. But this is the second highest week that we've ever recorded in these statistics. And I think it's quite amazing that deaths were allowed to get that high this time round, given what we learned, or what we should have learned from the first wave. So deaths by this metric will probably stay around this level next week, reflecting the deaths that occurred up to the week of the 22nd of January, around the time that deaths started to fall. So that's death data. And then finally moving on to vaccination data, which is some really genuinely positive news. It's something we can all be really happy about. So this plot shows the number of first and second doses, so first doses in blue, second doses in orange, delivered across the UK every day. So we're still seeing the majority of jabs being given our first doses, which obviously corresponds to the UK's policy of delaying the second dose. We're also starting to see a weekly pattern emerge in these vaccinations given, where we ramp up over the week and then we fall at the start of the week and we ramp up again. But last Saturday, we delivered over 600,000 jabs to people, which is really quite an extraordinary figure. And week on week, these numbers are rising. So we can hope tomorrow that we'll be giving even more doses of the vaccine than that. Again, just looking at first doses given, broken down by different nations. Red is England, blue is Scotland, green is Wales, and black is Northern Ireland. Again, you can see these are the total number of doses that have been given. You can see that we've given over 10 million people the first dose of the vaccine. Actually, that's over 10.5 million now, which is, again, really fantastic news. We're starting to protect some of the most vulnerable people in society. And again, just looking at the proportion of people, the proportion of the population that have been vaccinated across the different home nations, you can see that roughly everyone's doing a similar sort of job. Scotland lagging slightly behind, England slightly ahead. And then again, looking at the proportion of first doses given by age, and this is, again, really, really impressive. You can see that for over 80s, we've given 88% of over 80s in England their first jab, which is really impressive, because actually achieving vaccine uptake of 90% is actually a really difficult thing to achieve, and to do it so quickly is very impressive. Similarly, for 75s to 79s, we've vaccinated 83%, or sorry, jabbed, given the first dose to 83% of that cohort. So again, these are really impressive figures, and hopefully they will continue to rise as we mop up the last few people. So in summary, it's generally been a pretty good news week, apart from the fact, obviously, we're in the middle of a lockdown and there's all sorts of horrible things going on that we don't want to happen. We don't want to be in a lockdown. But in terms of the disease prevalence, that's coming down. Cases are falling, despite the inconsistencies in the data. The positivity rates are also falling, so that's really good. Hospital admissions are decreasing, as is hospital occupancy, but there is still extreme pressure on critical care beds and in general on the NHS. So those levels need to come down significantly. Deaths are coming down from near record levels, but again, that's good news. And vaccine delivery is improving week on week, and that's something we can really be happy with. And we've now delivered 10 million first doses so far. So that's all really good news, and I will pass back to Alice. Thank you.
Thank you very much for that, Kit. Reasons to be cheerful this week, and also extremely grateful for that amazing effort in getting the vaccination programme to where it is now. And now we're going to look at the new consultation document on reopening schools, as that is at the forefront of everybody's minds at the moment. And Professor Stephen Reich is going to introduce that. Stephen. Stephen, are you muted? I can't hear you.
I am, and you can't see me, but you can now. I started just by saying that as a Spurs fan, it's nice to have some good news this week. I want to make a couple of points, general points, in starting talking about our position on schools. The first one is that while at one level, Independent Sage is here to inform you, and Kit has given a wonderful example of that just now. We're also here to be informed by you and to have discussion with you, especially around fraught issues like schooling, something which is one of the most difficult issues, something which all of us care about profoundly. And the second point to be made is just the general framework, because education in many ways is unique, because it's of enduring importance. If you lose time at school, it's going to affect you for the rest of your life. It's going to affect you in terms of your social relationships, in terms of your physical relationships, and certainly in terms of your economic welfare over your lifespan. And that's why at Independent Sage, like the WHO, we endorse the principle that always schools should be the last to close and the first to open. And so with that in mind, on the next slide, I go on to talk about a number of general principles which inform our position. The first is that we want schools to be closed for as short a period as possible. We should make their reopening a so it is easier to reopen schools. And quite frankly, that's not happening right now. Although many people pay lip service, the mantra that schools should be last to close and first to reopen, there are a whole series of activities that are still going on. The number of people who can come in and out of our houses as estate agents, as tradespeople, as cleaners, and so on. The numbers of activities that we still allow to go on, like religious gatherings. The number of people we call essential workers who are still being required to go to work. The employers who are not sanctioned if they don't let people go home. The government, which doesn't pay for many people who want to furlough. So in many ways, if we want schools to reopen as soon as possible, we need to tighten the other restrictions to make that possible. And the other thing we need to do is we need to make the school environment as safe as possible so that reopening doesn't lead to great increases in infection. And although we're told that schools are already safe and nothing could be done, that self-evidently is not true. There are all sorts of things we could do to improve space. For instance, making outdoor spaces available, marquees and heaters and so on, making ventilation better and so on. So those are the things we need to do now so that we can open schools as soon as possible. The second point to be made, and again in line with this principle of last to close and first to reopen, is that the reopening of schools should be a priority and should happen before the reopening of other sectors of our society. It needs to happen first. And the timing, I mean, a lot of the time people will say, well, let's set a date for the reopening of schools. But that doesn't make sense because we don't know what the state of the pandemic will be, and therefore we don't know what the consequences will be. And so the timing of the reopening of schools should be driven by data, not by dates. That is, it should occur as soon as is possible without leading to the loss of control over the pandemic as a whole, getting back to the situation we were in a few weeks ago with the NHS under such stress, with such a spike in death. That can't happen again. But as soon as we can reopen schools without that danger, they should reopen. And the final general point I want to make is this. The impact of reopening schools is uncertain. There are many studies and they give us different results as to the impact of reopening schools, but we know it has some impact. So if we want schools not only to open, but to stay open, then we need to reopen carefully and in phases, looking what the consequence is, making sure that it's not leading to the level of infections increasing again, and when they can decrease further, then reopening schools more. So as I say, it needs to be phased and it needs to be careful. And what I want to offer here is an example of how this should be done. This isn't meant to be a blueprint. It's not meant to be set in stone. It's meant to be something which allows us to discuss these issues of how to phase in the reopening of schools. So it's illustrative rather than a blueprint. And in many ways, it's based on the Norwegian system, the traffic light system. So what we propose is that when R is less than 1, and when confirmed cases are less than 100 per 100,000 per week, then schools start to reopen with red safeguards. And red safeguards mean, in many ways, reopening in part. So this could take a number of forms. But one of the forms it could take is that some children are in school some days and other children are in schools on other days. So the schools aren't too full, and that limits the capacity for interaction and transmission. There should be other safeguards as well, such as wearing masks in class, and we suggest that that should happen for secondary and primary school children, as has happened in the United States without great problems, and that also there should be no large assemblies or gatherings. Having done that and monitored what the consequence is, if the consequence is not to cause further problems, then we can begin to think about when we would relax those safeguards still further. And so we suggest that when confirmed cases fall below 50 per 100,000 per week, then schools move to an amber level, amber safeguards, which then would allow all children to be in school at the same time, keep masks, keep the ban on assemblies and gatherings. And hopefully over time, as things improve still further and confirmed cases fall to below 10 per 100,000 per week, then we could go to green safeguards, which effectively means going back to a situation where we, beyond the basics, keeping social distancing, having good hygiene, wearing masks in crowded spaces, things pretty much go back to normal, a phased approach. The final point I want to make is this, and it's very important indeed, and that is that it's not good enough simply to reopen schools. We've also got to address the harms that have been done, and we've got to mitigate against them. Many people will give you statistics about the number of children who have mental health problems, and they talk about the economic impact, especially on poorer children. But that presupposes that we don't take action to change things. And if we don't want those things to happen, we have to take those forms of action. And there are three forms of action I want to focus on. The first is an old chestnut. We've mentioned it time and time again, and it's very basic. It's the need for computers, and not just computers, but Wi-Fi connections, and furthermore, appropriate study spaces for all school students. And that becomes more important with a phased return to school, because first of all, if you have some in school and some out, you still need that IT for the children who aren't in school. And inevitably, some children will have to self-isolate as there are outbreaks. And again, you need the IT so they don't suffer because of that. And so we insist that this remains extremely important, the provision of computers. The second is, and we talked about this a couple of weeks ago when we were talking with young people about mental health, the real importance of dealing with mental health problems when children return to school. The evidence suggests only 40% of schools have even got a counsellor. Only 20% of children, little more than 1 in 5, have been able to talk to any adult about how they're feeling. And so for years and years, people talk about mental health, and they talk about mental health being a priority, but nothing ever happens. And we need to increase support on mental health, not just within the NHS, in NHS settings, but in schools as well. So if people genuinely mean it when they say they're concerned about mental health, something needs to happen. And the final point is that, and it's going to happen very soon, we're going to have a whole cohort of children who are going to leave school, many of whom with their schooling severely compromised by the fact that they've missed schooling, and that will be far more prevalent amongst more deprived, more vulnerable communities, ethnic minorities, and so on. And so urgently, we need to think, how will that disadvantage be taken into account when they apply for jobs, when they apply for college, when they apply to university? And secondly, how will we replace those skills? How will we give them training courses? What will happen to foundation courses at university? We need to mitigate the harms, and that's the final element of our programme.
Thank you very much, Stephen. And that consultation document is, of course, available in full on the website. So it's time for questions. And I think first we've got Nigel Nelson of the Sunday People. Nice to have you with us again, Nigel. Are you there?
Yeah, I'm here, Alice. Thank you very much. Quick question on vaccines. Is it safe to give a different vaccine for a second dose? Or is it at least undesirable to do it that way?
Thank you very much, Nigel. It's not a new thing with vaccines, but it's obviously new for COVID. Professor Gabriel Scally, would you like to talk to that? Oh, you're muted. Everyone's muted today.
That's a very good question, Nigel, and one that lots of people have been asking. And it's a good week to ask it, because during the week, it didn't get a lot of attention, but a trial was announced to try and answer that question. In fact, to answer two important questions, if I can put your question about the mixing of the vaccines along with the question, is it safe to delay the second dose substantially? A trial has been announced with the two vaccines, the Pfizer vaccine and the AstraZeneca vaccine, involving 800 people. And one group of people will get Pfizer first and second doses. Some people will get that delayed second dose. So half will get it after 4 weeks and the other half after 12 weeks. And then another group will get the AstraZeneca vaccine first and second doses, again with those two different delays, split into two groups with the two different delays, 4 weeks and 12 weeks. And then the second arm of a major arm of the trial is the mixing. So one group will start with the AstraZeneca and then have the Pfizer, and another group will start with the Pfizer and then have the AstraZeneca. And again, both of those will be split into groups, some with 4-week delay and some with 12-week delay. So that's 8 different arms in this trial involving 800 people, and it's going to take a couple of months before there are any results, but it will answer those two questions about the mixing and also the delays. My own particular opinion is I don't think there's any safety issue in mixing, in having the two vaccines. The real question is what it does for immunity. And that's what this trial will answer. And there is a possibility that the mixing of those two vaccines, because they have different modes of operation, could actually give us a higher level of immunity than two of the same. Because you're prodding different bits of the immune system, essentially. So it might work out that way. And it might also give us more stability in terms of the variants as well, because they will generate a slightly different immune response. So the answer, I don't know the answer to your question, Nigel. I think it probably is safe, but we will know the answer before very long.
Thank you very much, Gabriel. Does anybody else want to comment on vaccines before we move on to the next question? I will move on to the next person then, who is Tom Magner from Carers World Live. Tom, nice to have you with us. What's your question?
It's always a pleasure to be here. I learn more in this 1 hour than I do most of the week. Vaccination progress for the most vulnerable in bands 1 to 4 is rightly welcomed, but we're also seeing practical issues delaying or denying the most vulnerable their jabs. This is possibly that final 10-20% that Dr. Yates was talking about. What we're hearing is typified by one field hospital in Wales, where the nearest bus stop is 20 minutes away on foot. And when you get there, often the forced to travel by expensive taxi, you'll find that the disability access features include wheelchair ramps that are too steep, and they're surrounded by potholes. So what can the panel advise policymakers to do to make sure that the most vulnerable are not left behind or left out because of practical problems that put them and often their accompanying unpaid care at a greater health risk while the general population's being vaccinated. Thanks.
Thank you very much, Tom. Gabriel, would you like to comment on that? And
another great question on vaccination. Well, I think the first thing is that there should be a set of standards, shouldn't there, for any place that's doing a substantial number of vaccinations, and the use of facilities should be judged against those standards. And it doesn't take a long time, I think, to write down a set of standards. You've mentioned several aspects there. I think what is also important is Kit was quite right about that final 20%, and you mentioned it. Getting that final 20% is really, really important. I know from running vaccination programs that you can get 60, 70% without the slightest difficulty. Get to 80, you're doing really well. But we really need this to be up into the 90s. There will always be some people who can't have it for various reasons, but really it should be up into the 90s. And I think that requires a different response. And it requires people to go out to the people and maybe vaccinate them. And that's where general practices and primary care teams locally can do it in a more intensified way. But I see my colleague Tolu wants to add to that answer. Thank you for the question.
Yes, Tallulah Oni, Dr. Tallulah Oni, would you like to comment here?
Thanks for the really important question. I think one of the things it highlights is the importance of seeing the vaccination process as exactly that, as a journey. And I'll situate your question in that broader journey. So often we talk about vaccination, we talk about getting the needle in the arm, but actually the process is right from getting the word out, making it easy for people to sign up. So, thinking about digital literacy and that sort of things, how we communicate to people, right through to thinking about the vaccination day. So how do we make it an accessible and pleasant experience, bearing in mind those different accessibility needs, and even through to the period after. So we know that, there's a waiting afterwards for 15 minutes, make sure you don't have any severe side effects, and supporting that recovery and maintaining that engagement. So I think your question really highlights the importance of seeing that whole journey, and across that trajectory, we have to be thinking about different needs. So how do we access people with physical accessibility needs, other forms of disabilities, that hearing, is that seeing, is that sort of thing, different aspects of society. So it really is critical that we see the vaccination more than just sending the letter out. So thank you for that question.
Thank you, Tallulah. And I think Professor Anthony Costello, you wanted to comment.
Yeah, very quickly. I went yesterday to get my vaccine with my wife, and it was completely brilliantly organised. And they took your information quickly, you queued it, all went through, it was quick. We had a query about some, medical data. They went to the computer, they typed in all the details, they came up immediately. And it was all run by a primary care network. So basically, teams of GPs, nurses, administrators had all got together. It ran smoothly, and that's why we've got a fantastically successful vaccination rollout. It's using the NHS. And if you want to, for those that want, it's a public-private partnership, because GPs are, if you like, private implementers. So my answer to you would be, I would, if there is a local situation like, people having trouble getting there and access, ring the local primary care network and just say to them, explain the problem. And I bet you they would come up with a creative solution. And it's just ironic, because we've been saying for the last year, why didn't we link our test, trace and isolate into this system? Because it could have worked extremely efficiently, and we didn't do that.
Thank you, Anthony. Right, we're going to move on to some questions from the public now. And we have the first one from Neil Denbo from Kent. Neil, are you with us?
Yes, thank you. I'm not a scientist, but as a layman, it seemed to me that a successful virus would be one that didn't kill its carrier. So would it be reasonable to expect that over time, the virus will mutate into a less deadly form?
Thank you very much for that interesting evolutionary question. And Dr. Kit Yates is going to answer it for you.
So it's a really good question, and there is a well-known law called the law of declining virulence. Unfortunately, that doesn't generally hold true. It's not actually a very general law, particularly for a disease like COVID, where the majority of the transmission is going to occur well before someone gets very ill and then goes on to die. There's not very much selective pressure on the virus to have to mutate, because it can infect people and then go on and kill them later. So generally, for these sorts of viruses, there's no reason to believe that over time it will there's no evolutionary law that says these sorts of viruses will decline in virulence, although there have been a couple of studies which are looking at the actual behavior of this virus, which suggests that it may well decline in virulence. So generally it's not a law, but there are a couple of studies which suggest that for this particular virus, it may be the case that it does decline in virulence over time and become less severe.
Thank you very much. And Kit, I wonder if I could come back to you on that, because obviously we are seeing evolution in action with the new variants taking hold, and the mutation that improves transmissibility obviously does mean that variant has the edge. Yeah, absolutely. So yeah, if you mutate to be more transmissible, then you can go on and infect more people, and you can become the dominant strain. That's what we're seeing in various countries that have got these new transmissible mutants, including our own country. But yeah, so the other important thing to say is that actually we might be more worried about a variant which is more transmissible than one that's more deadly, because actually if it's more transmissible and it grows exponentially, then it can infect a significantly higher proportion of the population before we get it under control, and therefore kill significantly more people. So a virus which is 30% more transmissible is actually typically much worse news if we're allowing uncontrolled spread than a virus which is 30% more deadly. If, for example, we're in the situation where we are now, where we expect to get control of that spread before it goes and infects the whole of the population. So yeah, sometimes these more transmissible strains can kill significantly more people than a more deadly strain might. Thank you very much. Does anybody else on the panel want to comment on that question? I hope that solved it for you, Neil. We're moving on to the next question now, which comes from Pete Matthews from Aberdeen. Pete.
Hi there, good afternoon. Thanks for the opportunity to ask the question. My question is about travel restrictions, and it's really about, what do you think the likely impacts are of not having managed quarantine for all UK arrivals? And a supplementary on that is, what do you think about the assumption that these types of measures are unworkable in countries like the UK and Northern Ireland? Thank you.
Pete, thank you very much for that question. Independent Sage has advocated for much tighter controls. And Professor Gabriel Scally.
Yeah, I suppose it's because I come from Northern Ireland. I'm interested in borders, and I used to work along one, and I know how permeable they can be. But borders are really, really important, and the controls are really important. They always were important. The Home Affairs Select Committee, in its report that came out during the summer, was absolutely scathing of the government's failure to put on proper public health controls at our borders at the very beginning of this pandemic. And as you know, the virus has flooded into the UK and into Ireland in that early period. There is another big issue at the moment, and that is the variants coming in. And the more virus there is replicating in any territory, the more mutations are likely to take place, and the more risk there is of some new variant popping up with characteristics which will be, as Kit said, they could be more transmissible, they could be more deadly, they could avoid the vaccines by changing their genetic code to a greater or less extent. So at the moment, I think there are two real pressures in favor of having quarantine measures, managed isolation measures for all arrivals into these two islands. And that is to stop the possibility of variants coming, and secondly, to stop new cases coming in, because we are very hopeful that the government will take the action to drive down the levels and drive it down by improving their testing and tracing and finding, isolating, supporting system, including doing things that they have never done, such as testing all close contacts, which is the guidance from the European Centre for Disease Control and the guidance from CDC in Atlanta to do that. And the UK has never done that, and it should be doing that. But it is possible to drive down the numbers. But there's no point in driving down those numbers, as Scotland successfully did, as Northern Ireland successfully did, as the Republic of Ireland successfully did last summer, if you're simply going to reinfect the place with new cases. So for two reasons, border controls and managed isolation in particular is very important. The question is, can it be done in these islands? Of course it can be done in these islands. It can be done successfully anywhere. In fact, putting it in place now, we have a fantastic opportunity to learn from the experience of Australia, New Zealand, Taiwan, and all the other countries that have done it. And from places closer at hand, the Isle of Man should be congratulated for having become zero COVID and for having reopened and dropped all their domestic restrictions. So yes, it can be done. It's an issue of willpower and organizational capability.
Thank you very much, Gabriel. And Kit, you wanted to say something here.
Yeah, just on measures that the government are currently implementing, they are doing some managed isolation from these red list countries, but it doesn't go far enough. It's sort of a half measure, and there's almost no point doing these half measures, because putting restrictions on particular countries doesn't stop variants from those countries coming in. People find creative ways of getting to a country if they want to do that. People don't always take the most direct route to get from A to B. And we've seen that with these various incidents of the South African variant having arrived, despite the fact that South Africa, direct flights from South Africa have not been allowed since the end of December. So people are coming to our country with other variants. So if variants are the thing that we want to stop, and there are plenty of other reasons for wanting tighter border control, but if variants are the main argument that the government will listen to, then it doesn't make sense just to stop flights or to use managed isolation just from some countries. It really has to be from everywhere or from nowhere, not bother.
Thank you very much for that, Kit, and thank you for the question, Pete. And I think we have a related question now from Laura Bearsall Moore from Suffolk. Laura.
Hello, thank you for having me. Yes, Gabriel did touch on some of the issues in my question, but I wondered if there was a bit more detail on how have countries that have done relatively well in keeping their case numbers down, where they are also an international travel hub, how have they done that with their border controls? For example, Japan has Tokyo, Thailand has Bangkok. So what can we learn specifically about what they've done, particularly in those international travel hubs?
Gabriel, I'm probably going to come straight back to you on that one. And then if any of the rest of the panel want to comment, let me know.
Because it's a very good question. And of course, it is used as an excuse for not doing it in the UK. Well, this is a travel hub for the world, indeed. That is to a certain extent true. And Ireland uses this as well. And they're saying that it's not in their culture or nature to be a closed society and close down travel. But the point is, travel has shut down remarkably across the world. What I'm seeing at the moment are two pressures. One, the real pressure to curb unnecessary travel, and then the leaflets that are popping through my door encouraging me to book holidays with various places or go on various airlines. And in terms of the travel hub issues, those can be handled. Some of the busiest air route in Europe is between Dublin and London, and I'm quite clear that could be stopped tomorrow. And if it needed to be there, managed down isolation, we mightn't have to close that busiest route in Europe if Britain and Ireland had a two-island solution to this. Taiwan has one of the busiest air routes in the world. It's a real hub for Southeast Asia, and they've managed it perfectly well. And there is a possibility of having, good COVID-safe transit in transit lounges in hubs. I'm quite sure that can be done, but it is a problem, and it's a problem because of this issue of people dodging around the world, booking separate flights with different airlines, maybe taking a train in between to get to somewhere that they're allowed to come from rather than somewhere they oughtn't to come from. So I think it can be done, and should be done. And and if the hubs have to slow down and stop, well, the airline industry is slowing down and stopping for passengers. I think the important thing to point out is that air freight continues, and I have yet to hear of any outbreak associated with air freight, which seems to be operating perfectly normal through the pandemic. So I don't see why not it can't operate in an era of hubs. Thank you.
Thank you very much, Gabriel. Anthony, did you want to comment here?
Well, just quickly, the question is good. What can we learn from all the countries that have suppressed their epidemic? And of course, one aspect is border controls. But I would remind all those people who are saying, oh, people like Indy Sage are continually wanting to lock down. The countries that have suppressed this virus have had no national lockdowns, none of them. China, South Korea, New Zealand, Australia, they've had partial lockdowns, but they've managed it in a totally different way. And of course, their death rates are hugely different. I mean, China, Vietnam, Thailand, Taiwan, they've all got death rates below 3 per million. We're at 1,600 per million. So it's massive, and we do need to learn from them. So one thing, and I know we say this every week, isolation. The most important thing is to isolate cases, to take them out the system, and then everyone else can get on with their lives. I looked at sick pay levels. In the UK, you get £96 per week sick pay, unless you all less than 100, get nothing. That's for 2 million people. All right. If you look at Canada, the same level is £296. New Zealand, £308. And our inputs are way than it's something like a third of the median income. Oops, have I gone wobbly? Can you still hear me?
You went a bit wobbly, but we're definitely getting the gist.
Yeah. Okay. Sorry. So the big fear we have, and Christina's not with us today, but I know she's fearful that, you know, in another month's time, we may be able to open on March the 8th and things will have come down, but cases are just going to rise again because we haven't got this system in place. And people will say, oh, well, we vaccinated 20 million people. They're the most vulnerable, which is true. Deaths will come down. But 47 million people will be left where it's circulating. And at the moment, 70%, I think the figure, Kit will correct me, of ICU patients are under 70. So there's a lot of young people there, or youngish people, who are in ICU. There's all the long COVID issues, and then all the risks of mutation that could undo all our vaccination program. So this isolation payment issue has been hanging around for a year, and nobody's addressed it, to add to all the border things that Gabriel.
Thank you very much, Anthony. Zubaida, I wonder if you wanted to come in there, because this is an area that you've been worried about previously.
Well, other than just to say, I think Anthony's absolutely right. You know, right now we've got three things that are constantly being talked about, which is lockdown and when is lockdown going to end, and we're obsessed with the dates. You know, we're rightly obsessed with vaccination. And of course, you know, as Kit has says, that's been going brilliantly, but vaccination isn't going to bring the cases down, and it's not going to be keeping the cases down. Vaccinations is about protecting the vulnerable. It's about reducing deaths. So this whole issue of how do we bring cases down, and more importantly, ensure they stay down, is, as Anthony says, around self-isolation and the supported self-isolation. You know, I know Jeremy Hunt has spoken about this and is absolutely right to say, why haven't we addressed this, particularly given that it can't be a question of money. When the government has poured so much money into the failing test and trace, the privatized test and trace system, which is over £22 billion, and then is stingy around, you know, the sick pay, and also around supported sick pay, the £500 a week. It's a really huge problem. We still have less than 1 out of 5 people self-isolating. And as Anthony says, if you can't self-isolate them, then we're not suppressing the virus.
Thank you very much, Zubaida. Stephen.
Yeah, I'd really like the question, because the question is about learning. And I think one of the reasons why we're in the mess we are in is because we're not learning. And one way of learning is from places elsewhere in the world, and those who support self-isolation, for instance, they do so in New York, and they get 80% of people to self-isolate. The other form of learning is from our own mistakes, and we're not learning from our own mistakes. And the two big mistakes last summer, I think, and I live in Scotland, where we got the rates very low, were number one, not to support people to self-isolate. Now, Dido Harding in Parliament a couple of days ago gave a figure of 20,000 people wandering around in our midst infected because they're not self-isolating. She was very optimistic with that figure because she took the one study which shows the highest levels of adherence. If you look across the piece, probably it's more like 40,000 than 20,000 people at any one time infected, not self-isolating. And the second mistake that was made was not to control borders. And Scotland, for instance, was down at very, very low levels indeed, but we reseeded things. And again, 21,000 people are coming into this country every single day who might have new variants, we don't know, and there is nothing to make them self-isolate. So those two lessons are very, very clear lessons, and we need to learn from them. And this government needs to learn both from overseas and from its own mistakes. And it will point very clearly to the point about borders and the point about self-isolation as two gaping holes in our response.
Thank you, Stephen. And Susan Mickey, Professor Susan Mickey, you wanted to add something here.
Thanks. Yeah, just to add to what's been said, one of the ways we learn is looking at data. And I'm involved in a weekly survey of 2,000 people across the UK. And one thing that's become very evident is when you look at the people who say they can work from home full time, 1 out of 5 of those people are going out to work. And when you look at who they are, these people are low income, and they're also people who suffered financial hardship as a result of COVID. And if you put that together with some other research that's been done in the Borough of Newham in London, which shows that the reason that people are going out is not just low income, that's a huge driver, but also an incredible fear of losing their jobs. A lot of people in precarious jobs, and they just think if they don't go into work, they'll lose their jobs. So this is something that absolutely urgently has to be taken on at a government level, because it's about employers and good employment practices, as well as the good working conditions, which we've talked about a lot in terms of protecting people from infection. So in order to learn, we need to know why the things that are happening that are driving transmission. And that's a very obvious one that needs to be tackled urgently.
Thank you very much, Susan. And I think that I spotted Professor Carl Friston's hand up as well. Carl, you wanted to comment here.
I did. I just wanted to add to the chorus or tell exactly the same story from a purely theoretical point of view. So one very nice way of looking at the reproduction number is it's the product of 3 things which form the targets of interventions and things we can do. So it's the contact rate times the transmission risk times a mean infectious period. So if we just think about the things that we do to try and reduce that reproduction ratio, the contact rate, that's lockdown and travel restrictions. The transmission risk can be, to the extent that vaccination reduces transmission rates, is the obvious big hope in terms of reducing transmission risk, but also the other sort of mask wearing and other sort of socio-behavioral responses. That leaves, and both of those I think are well covered at the moment. We're well into a lockdown and we've got a great vaccination program. That leaves the final thing, which is a mean infectious period, which is the target and the raison d'etre for isolation. You isolate, you remove, so people don't have the time to infect somebody else. So from a purely theoretical perspective, that's the missing focus and the missing target, I think, from our overall current strategy, speaking again to the points that have just been made by the past 4 speakers and implicit in the question: isolation, quarantine, getting that immune infectious period down to complement the vaccination efforts and also all the efforts that's going into lockdown.
Thank you very much, Carl. And Tallulah, I think you also wanted to comment on this question.
It was, thanks, Alice. It was just to pick up on Stephen's 2 lessons, and I was going to add a 3rd lesson, which is the importance of learning from the past. So if we look at the examples of other pandemics we have gone through, for example, HIV, one of the things that we've learned is that we need global action and global solidarity. So in as much as we talk about the importance of supported isolation, really critical, border management, travel restrictions, in the medium term, forget the long term, for us to have a sustained chance at keeping zero COVID, we have to be ensuring that not just our population is vaccinated, but actually globally, there's global action to get particularly the most vulnerable across the world, but really spreading the vaccine distribution equitably, not as an act of charity, but actually as in our best interests to get back to normal as quickly as possible. So I think that's one of the lessons from the past, that we are all in this together and global action is going to be needed for us to come out the other side.
Thank you very much. And thank you for that question, Laura. Well, I think you've won the prize today for the most comprehensively answered question on the Independence Age Friday briefing. I'm going to squeeze in one more question. It comes from Karen Hurley from Hampshire. Karen.
Hi, so my question is around quarantine. So recently in New Zealand, a couple of people tested positive just after coming out of quarantine, which got me thinking, is one of the problems of why these new variants are so contagious is just simply that their incubation period is slightly longer than our quarantine. So people are coming out of quarantine feeling like they're safe, and they're coming out just as they're most infectious, because we know you're just as most infectious just before your symptoms start, which obviously throws up a whole heap of questions, including, do we even have these metrics to hand? Because I've had coronavirus and I've had to isolate numerous times in my kids' school bubbles, and at no point were we kind of linked together of, were you quarantining before you became infectious? So are we even able to gather that metrics to find out if people are coming down with coronavirus just after coming out of their quarantine periods?
Thank you very much, Karen. Gabriel, can I come to you for an answer to that?
Yeah, good question, Karen. I think it's a long time since I looked at the paper, because it was established really pretty early on in the pandemic that, like many other human characteristics, there's a sort of bell-shaped curve, a normal distribution curve, it appears, in terms of when people become infectious and develop the infection, the incubation period. And it has a long tail to it, and 21 days, it's out around there that people really stop developing the infection. That's what, as I remember it. And but certainly the vast majority of people should have, if they're incubating it, should have developed the infection enough to either have symptoms or to have positive testing. And by 14 days, and that's why 14 days is generally used. And you'll remember that a little while ago, the UK government cut their isolation period to 10 days because they felt that that was enough. It isn't regarded as enough internationally, but clearly it is in the UK. And it's one of the difficulties, talking of borders, in that depending what side of the border you are in Northern Ireland or the Republic of Ireland, you can cross a bridge and you'll have to isolate for 14 days on one side and 10 days on the other. So there is no final limit to it that I have seen, but cases certainly have been spotted developing the disease after an incubation period of over 20 days.
Thank you very much, Gabriel. I wonder if I could press you on that. Do you think that the decision to reduce the quarantine from 14 to 10 days was a purely economic decision?
Well, I think it was driven by the desire to get back to normal, irrespective of what actually happened to the virus. So someone worked out that maybe 10 days dealt with 95% or 90% of the cases or something, and said that's enough. And because and it speaks volumes of the government's approach to this, which is to live with the virus and not to eradicate the virus, because eradication doesn't work on 10 days at all. But you can dampen it down, but it's not a get rid of the virus approach, and that it's unfortunately the government has never had a get rid of the virus approach.
You mean elimination, Gabriel, not eradication?
Yeah. Sorry, elimination, not eradication. Yeah. It is a huge problem because it will get it down to low numbers, but it won't eliminate it, i.e. stop all community transmission at 10 days.
Thank you, Gabriel. Quite a few people want to comment now. Susan first.
Just on the elimination versus eradication issue, which I've got wrong in the past, and most people aren't aware of this nuanced distinction, but it's really important. So elimination is getting rid of the virus in a region. Eradication is getting rid of it everywhere. So the zero COVID strategy is about elimination, which is getting rid of it in regions, acknowledging it will pop up occasionally, which is why one needs the excellent test, trace and isolate system. On the issue of 10 versus 14 days, yes, it seems to be yet another British exceptionalism that's not serving us well. And one of the arguments that was put forward at the time was instead of actually dealing with the problem of self-isolation by understanding what was causing the problem, which means realizing that it needs to have practical and financial support attached to the policy, people were saying, well, maybe if we shorten it, then there'll be greater adherence. The problem is, when you look at the data, the evidence shows that there's no more going out of the house between 10 and 14 days than there was before for those who were leaving the house. So I completely think that we should be calling for the 14 days unless anybody can give a really good argument as to why not. If we're serious about getting rid of this virus and getting out of this pandemic as quickly as possible to save lives and save the economy, we should be throwing everything we have at it. Why aren't we?
Thank you, Susan. Stephen, you wanted to comment, and then Cole.
In many ways, I just want to back up Susan's point, because I think it's absolutely critical and is emblematic of a government approach which has been incredibly unhelpful in terms of securing adherence. Because what it does is it presupposes that the problem lies in the public and the public weakness and the public unwillingness to self-isolate. That's not the problem at all. People want to do it, they simply can't do it. So the failure is not one of the public, and the failure isn't one of the frailty of human psychology. The failure is that of government and of policy and of giving people the support they need to do the right thing. And in so many ways, the government needs to pivot away from assuming the public is the problem and blaming the public and moving towards supporting people to do the right thing. That's the way forward.
Thank you, Stephen. And Carl, come to you for the final word on that question.
Thank you. Final technical word, just to come back to the sort of the quantitative perspective. So remember before I was saying that the reproduction rate, the exponential growth, is proportional to three things. And the last thing is the mean infectious period, which is usually read as the incubation period plus half the amount of time that you're infectious. So it's a really important determinant. So for example, if your mean infectious period or incubation period increases by 20%, that means exponential growth will increase by 20%, and roughly R will increase by an enormous 0.2. So it's a crucial epidemiological parameter. The reason I'm going into that is it is possible to estimate it, but you need quite a lot of data, and you need to be able to measure the exponential growth. So they're always rather retrospective estimates. And the best work that I know of that's addressed that specific question is by Imperial College, and they were looking at the new variant, the new Kent variant, and they looked specifically, was there any evidence for the new variant increasing the mean infectious period or the incubation period, and there wasn't. Now, it doesn't mean to say it's not there, but there wasn't sufficient evidence for them to say that it was there. So that's quite a comforting result. So people do look when they can.
Thank you very much for that, Carl. And Karen, thank you very much for that question. So I'm going to draw things to a close almost, but as always, give Sir David King the opportunity to sum up. Over to you, Sir David.
Well, thank you very much. I think what we've heard this week is that it's a good news week. Lockdown is working across the United Kingdom. But let me just remind everyone, we still have 9,000 deaths per week. This is an incredibly high death rate. Vaccination, the rollout is very impressive. 10.5 million have had a single jab already, and that is a very, very important development, and we congratulate the government and the National Health Service for rolling it out so efficiently. Schools, still the vital issue. We're all concerned about schools not being open right across the board for children, and we would like to see that altered very quickly, but we need to prepare the schools for that process. Now, what I'm going to come back to now is the strategy for emerging from lockdown. There should be much more discussion about what that strategy should be. And I would say, no, it isn't a question of saying when the number of new cases per day is down to a certain number, whether that number is 5,000 or 1,000. And these are some of the numbers that have been bandied about per day. We can only emerge when virtually every new case is identified. We come back to the importance of find, test, trace, isolate, and support. We also cannot emerge from this pandemic until we have a full support system to see that everyone is able to isolate and is supported in order to be able to do that if otherwise they couldn't. We are very, very keen to see that we come to an end of this pandemic as quickly as possible. And that is the vital part of the equation that is so far not being addressed by government. And we would really press upon them, what is the strategy for emerging from this pandemic? Thank you.
Thank you very much, Sir David. Thank you to everybody who's engaged with this briefing today, whether you're with us live or catching up. And thank you very much for all of your questions. Thank you to our incredible team of experts here. They're all volunteers who believe this sort of open communication is vitally important. We hope this independent view and sharing of the latest science is useful, but it's equally useful for the scientists to hear from the wider public as well. As Professor Stephen Reicher said earlier, Independent Sage is there to inform, but also to be informed. And we've also heard today how we really need to be open to learning from our mistakes, learning from other countries, and learning from the past. The new consultation document on schools reopening and all of the other Indie Sage reports are available on the website, along with details of all the scientists here. Please follow Independent Sage on Twitter if you don't already. We'll be back same time, same place next Friday. Stay home if you can, stay safe, keep well. Thank you, everyone.
Thank you.